I'm Dr. Jessica Gannon from the American Society for Clinical Psychopharmacology. Welcome to our podcast. Today, we're joined by Dr. Perry, Dr. Katharine Liang, who's on the end there, and Dr. Nicolette Stogios. Hi, everyone. So I just finished watching you guys give a very compelling symposium on metabolic syndrome. And so I think to just start out, um, I think we can all agree that most clinicians in psychiatry know the importance of detecting metabolic syndrome and treating it, but specifically in patients on antipsychotics. And I think that one of the main points that you guys conveyed today was that this may be a bit short-sighted and that really there is some transdiagnostic importance and importance of detecting for metabolic syndrome outside of those patients on antipsychotics. And so I don't know if one of you wants to jump in and talk more about that, or why might you think it would be important to test for metabolic syndrome in people not on antipsychotics?
I suppose I'll start. I think there is a growing understanding and a growing awareness of these problems, mostly focused on patients prescribed antipsychotics at the moment. But at least where I work in Great Britain, we don't yet see that translate into meaningful action.
Mm-hmm.
We don't see the prescription of therapeutic interventions or preventative interventions. So we have an audit every year for physical health in psychosis services with some other standards as well, other important outcomes in psychosis services. And we see that our clinicians are really good at screening for metabolic health, but not very good at offering suitable interventions that are easily available in practice. So I think, at least in Great Britain, we might even be a bit further behind if things are better in the States. We still have quite a lot to do in terms of improving the interventions that we offer. And that's for patients prescribed antipsychotics. And I think what we heard in the symposium is actually we see the same risks for patients with other mental health conditions, not prescribed antipsychotics as well.
Yeah, I know, Dr. Liang, a lot of your work has been done in individuals with post-traumatic stress disorder. And I know you spoke today about specifically an analysis of a data set that you conducted in looking at metabolic syndrome in Black women in Atlanta with both diabetes and PTSD. And so, picking up on Dr. Perry's assertion there, would you find that, early detection might be helpful in this population? And then can you explain how and why?
Yeah, I mean, I think certainly I think understanding the biological pathways that lead to metabolic disturbances is really important, because I think it may be different in the mental health population, and maybe even be different depending on which mental health disorder we're looking at. In the population that I'm interested in, specifically patients who have been exposed to trauma, there may be a noradrenergic pathway that is independent of medications, independent of antipsychotics, that may be driving metabolic disturbances. And so I think it goes beyond, the risk factors of what medications patients are on, and really looking at the pathophysiological pathways that are disturbed in patients with mental health disorders.
Oh, thank you. And I know, Dr. Stogios, to turn it over to you for a minute, I know that you were looking at a population of folks who aren't necessarily diagnosed with a comorbid mental health disorder, but do have a diagnosis. And spoiler alert, it's intellectual disabilities. And you were talking about just how often these folks are neglected in general in our research, but especially in terms of cardiometabolic risk detection. Can you speak a little bit more about that?
Yeah, so it's so these individuals are often underrepresented in clinical research, as I addressed, but at the same time, from the clinical perspective, there are no population-specific guidelines to address cardiometabolic health in these individuals, despite the fact that they do have an intrinsic vulnerability to heightened metabolic risk. As I mentioned in the talk, they close to 50% of these individuals with these diagnoses are overweight or obese. They meet criteria for metabolic syndrome. So despite knowledge and awareness that there's this intrinsic vulnerability that then's further compounded by the medications that they're taking that induces metabolic side effects, there currently is a lack of kind of pathway algorithm or any specific guidelines to address these issues. So it's very important for clinical research to tailor or to conduct research specifically for these individuals, as the findings that for certain metabolic interventions that have been seen in other patient populations that are on antipsychotic medications may not necessarily generalize or be applicable to this specific population. So it is important to conduct research and from the clinical perspective as well, tailor interventions specifically for these individuals.
Very important point, because I think, starting off, thinking about this transdiagnostically, how important detection is and treatment, we are seeing, and you guys are explained to us today, that there may be differences in intervention that are important to take into account when looking at specific populations. And so, Dr. Perry, I know you've done tremendous work in developing a model called a Psychiatric, which you discussed today, some of the different factors that you incorporated in version 2 of this model. And you also talked about implementation of this model and how that's coming along so far. Can you tell us, the audience, just a little bit about what Psychiatric is and how it can be useful clinically in detection and in helping inform treatment?
Thanks. Yeah, so Psychiatric is a prediction tool, risk calculator, tailored and accurate for young people, well, predominantly young people, following a first episode of psychosis. So we have population-based tools that have been around for decades that underserve this patient group substantially, significantly under-predicting the risk. So Psychiatric is a tailored and accurate tool specifically for the psychosis early intervention population. We have ongoing research studies to explore the utility in other patient groups, so young people with mood disorders. Interestingly, we'll start soon a study with young people with intellectual disabilities as well. So we think that there will be clinical usefulness in other patient groups at the moment. At the moment, we have a tool that we've developed into a web application. We've taken it through regulatory approval in Great Britain. So it's to our understanding, the first clinically available prediction tool in the field of psychiatry that focuses on metabolic health. So from routinely collected information at baseline, we can predict the risk of clinically significant weight gain within a year, metabolic syndrome within 6 years, and diabetes within 10 years.
That's great, and all of interest to those of us who treat patients in this population, because this is my specialty area, by the way. So one of the things that came up, a comment today that I felt really compelling as a clinician, was there was a gentleman, a physician, who asked a question about, could such models be harmful? Could us exploring as psychiatrists, risks with a vulnerable patient who may not have the best insight, could that backfire? Could that lead them to go off medication? How have you dealt with that in your trials? And maybe you could summarize here how you responded to that individual, because I thought you did a really good job.
Thank you. Yes, so any change to a health system, any intervention that we integrate into clinical pathways can have either positive and negative or both consequences, and we have to explore for those. And I think there's a growing understanding that particularly AI and prediction tools, if we don't really think carefully about them and we don't assess them properly, not only before they're implemented, but after they're implemented as well, could contribute to worsening healthcare inequalities. One particular factor that's come up very, very often when I've spoken about Psychiatric, and actually in peer review comments as well, when we went through publication, but also in our stakeholder focus groups, was the risk that if we deliver risk information to patients, do we increase the risk that patients stop taking their medication? And that is something that we have thought very carefully about in our stakeholder groups, in our interviews, and we have a whole section in our physical health risk communication guide that is available for download on the web application that focuses on medication adherence specifically. I think there is an ethical point to psychiatric practice at the moment. We are told that we have to give patients an informed choice with medication, and I think if we understand that there are metabolic risks associated with antipsychotics, we do need to be open and honest about that. The timing for those conversations, I think, is very important, and that's something that we're thinking about now, is when is the best time to use Psychiatric. What we aim Psychiatric to be is to be a resource that enables shared risk understanding, and we think shared risk understanding between clinician and patient will encourage shared decision making and ensuring that clinicians and patients are on the same page with mitigating interventions that we can take to prevent any adverse long-term metabolic consequences. That said, though, we are tracking impact evidence for Psychiatric in Great Britain, and if we do see evidence that Psychiatric's contributing to worse medication adherence and adverse psychiatric outcomes as a result, then we will take steps to address it.
Thank you. Dr. Stogios, thinking about clinical applications of thinking about preventing metabolic syndrome in the IDD population, I know a hot topic right now in the United States, at least, is deprescription, and I think it came up today in the talk that some of the folks that are in your sample population may have been on antipsychotics for quite some time. Do you think, and I know that you have mostly a science background, but work closely in metabolic clinics, do you think there may be a role for thinking about this in terms of deprescribing some antipsychotics?
Yeah. That's a great question. Again, it's a bit difficult to answer from the non-clinical perspective, but of course there has been evidence for the use of these medications in these populations for treating specific symptoms, and given sometimes the kind of lack of access to care, these are often medications that might be prescribed as just a kind of an easier approach to be able to address some of these issues. But at the same time, the metabolic, from the metabolic perspective, the side effects and the risk that it adds to these individuals should definitely be taken into consideration. And I know that my talk was focused on the pharmacological interventions to kind of mitigate metabolic risk in these individuals, and that only kind of adds to pill burden, and there's a whole slew of issues that arise with that in terms of compliance and adhering to additional medications. But given the intrinsic risk that these individuals, or the heightened risk of these individuals in terms of their metabolic health, and then the added risk of the medications, and sometimes the difficulties of engaging in certain behavioral interventions or adhering to lifestyle changes, given the inherent kind of challenges associated with these diagnoses themselves. Sometimes these additional medications seem to be the most effective approach to addressing some of the metabolic challenges encountered by the patient population. So I think, of course, in an ideal world, taking a stepwise approach and trying to first address certain issues without medications and non-pharmacological approaches, behavioral interventions, lifestyle changes, definitely should be the first line of approach. But we do see the safety and effectiveness of and early uptake in these populations of certain medications as well, and the beneficial outcomes of it. So I guess it's all about striking a fine balance to ensure that everyone's needs are being adequately met while not necessarily over prescribing when not necessarily warranted.
Yeah, and I know that in your research you found that there was benefits of, like you said, the pharmacological interventions that are commonly used, like metformin, at a relatively low risk. And so I think that was a really heartening message in your presentation as well. So Dr. Liang, I think, you spoke quite eloquently about clinical interventions in, your population. and thinking about this, more broadly, how might you see effective interventions in PTSD, taking into account metabolic status? Like, how does that impact, the illness progression and outcomes, and how might be a way that you would attack this clinically?
I think one of the take-home messages of the preliminary data that we have is that mental and physical health are just so intertwined that really we're doing a disservice to our patients if we're only focusing on one and not really looking at the outcomes in the other categories. So I think taking into account, all of these outcomes and measuring, measurement-based care is becoming a bigger thing in psychiatry. And maybe we also need to be looking at more than just the psychiatric questionnaires. Maybe we also need to be looking at patients' labs regularly and really assessing both, because I think that the physical health outcomes are going to be influencing in all of these complex pathways, feeding back onto the mental health symptoms. So, I think that a more integrated approach to caring for these patients is going to be important, especially when we've seen over time that sometimes there is a gap in, we expect as psychiatrists that the physical health stuff is going to be taken care of in the primary care clinic or in other specialty clinics. But the fact of the matter is that a lot of these patients just, we're the only doctors that they see. So I think it is important for us to be thinking about all of these things.
Well, and you showed too that, diagnostic comorbidities can be, in psychiatry, can be really important to account for too, especially like the prevalence of depression in this population, and how that can impact outcomes.
Yeah, for sure. I think there's evidence that suggests that worsening depression can feed back into worsening insulin resistance, and vice versa. Same with PTSD symptoms. So, I think that that's something that is underappreciated, that mental health symptoms themselves, even independent of the effect of mental health symptoms on behaviors, just the expression of mental health symptoms themselves may be impacting the metabolic outcomes. And I think that is a kind of a newer way of thinking about it, and something that deserves more attention.
Yeah. Thank you. Well, thank you all so much for joining us today. We're really, really grateful. And thank you very much to our viewers for joining in.